This conference will now be recorded.
Hello, everyone. Welcome and thank you for joining us for today's ACRM Pandemic Webinar, which is part of a series of webinars produced by ACRM and the ACRM Technology Networking Group to help bring needed information to rehabilitation researchers and clinicians regarding the use of telehealth during the pandemic. My name is Jeanne Zanca, and I have the honor of moderating today's webinar. I currently serve as the immediate past president of the Spinal Cord Injury Interdisciplinary Special Interest Group within ACRM, which contributed to the production of today's webinar. Today's webinar is entitled Rehabilitation Now and Forever, and will be presented by Dr. Marcalee Alexander, who is president of Telerehabilitation International and clinical professor of physical medicine and rehabilitation at the University of Alabama at Birmingham School of Medicine. Before we get started with the presentation itself, I wish to advise all participants that this meeting is being recorded. Please keep your phones and microphones and your webcams as well off and throughout the whole of the presentation. We do expect to have approximately 20 minutes at the end of the presentation available for discussion. So if you have questions, please type them in the chat feature and we'll address as many of them as we can in the later part of the hour. With that, it's my pleasure to introduce our guest speaker, Dr. Marcalee Alexander, a physiatrist with special expertise in spinal cord injury. She was the first female president of the American Spinal Injury Association. Most known for her research in sexuality and spinal cord injury, she is a firm believer in translating research into practice. Dr. Alexander is passionate about the benefits of telerehabilitation, having worked in this area since 2012 in multiple settings. As an adjunct to traditional healthcare, she and international colleagues launched the YouTube channel, Sustain Our Abilities, to share information about rehabilitation, quality of life, COVID, and the climate crisis. She also started the nonprofit organization, Telerehabilitation International, and is walking from Canada to Key West, Florida, to highlight issues related to accessibility, disability, and disaster. Dr. Alexander, we look forward to your talk, and I gladly turn the presentation over to you.
Thank you so much, Jeanne. I appreciate it. And thanks everyone for being here now and listening and watching the presentation. And I hope it's useful information for you. So we're going to be talking about telerehabilitation. Before that, I just want to give my disclosures. I have, as said, written an ebook, and I am on the Scientific Advisory Board of Dignify Therapeutics and was fortunate in being able to create a nonprofit. But those are all non-paid positions. So today, what are our learning objectives? Well, what I want to do today is really give you kind of a broad overview of telerehabilitation, kind of a step back, so we can look at what people have all jumped into and what the potential is for the development of telerehabilitation in the future. So we want to identify at least 3 different techniques for telerehabilitation, at least 3 different uses for telerehabilitation in clinical care, and at least 3 benefits of the performance of telerehabilitation. So this year hasn't turned out the way we all expected. You know, the new year started, everything was going ahead, and we all had plans, and then all of a sudden plans changed. I happened to be at the AAP meeting, and amidst the middle of the meeting, people started going home because they were called home from their institutions. And this was clearly not something any of us had ever experienced before. And as that happened, the world changed. And clinicians all over the United States and other parts of the world had to rapidly adapt. And all of a sudden, telemedicine became the norm. And in fact, people were told to do telemedicine. I've got a license in Florida, and I got a note from the governor saying all practitioners should be doing telemedicine. And telemedicine was never funded in the past. So obviously that's a change. And what we want to do now is review what we've been doing and see if we can tweak things to maybe do them a little bit better in the future and a little bit more, with a little more finesse. So before you think about what you're doing in your telemedicine visit, or telerehabilitation, as I like to say, it's important to go back, and I have to credit a lot of what I do to having worked at the VA. The VA has had one of the best systems in terms of education and development for telemedicine. They've been doing it for quite some time, and because they haven't had the issue of insurance coverages or the issue of going from state to state, they've been able to do a really good job and develop their system. So when you start performing a visit, what do you need to do? Well, you need to kind of think about what you're doing. Just like you have a slide set for giving a lecture, you have a script. And if you're a physician, that can be your basic history and physical or your basic visit. And if you're a therapist, it can be your normal treatment protocol. So you've got your script, you know what you're going to be doing. You make sure you have access to patient information. And this is important. The other thing that's important is with your patient information, if you are doing telemedicine or telerehab regularly, it's a nice idea to have two screens. One screen where you can just see the person and another screen where you can have the chart available. This makes it easier to look up information from the past and also to document new information. You've got to perform informed consent, and I really do this anytime. All the time. Until I've seen a person a few times, I'll say, we're just face to face on the video. I can't have hands-on with you, so it's different than a regular appointment. And the other thing is we need to use HIPAA compliant platforms. And this is something that's changed recently, and there haven't been the same requirements, but I'm sure as we get past Corona, we will need to go back to using HIPAA compliant platforms if you're not already doing that. The other thing is know your timeline. You can get away, if you're a physician, you can get away with having a number of patient visits and then getting behind a little bit, but with telehealth, not so much. You really need to stay on target and be respectful to the people that are in the virtual waiting room. It's good to have an emergency number. If anything happens to the person, or if your phone just cuts down or the video cuts down, it's good to know where to call. Also, it's good to know their emergency number. Do they have 911? Do you need to have the police department number available? And then it's good to practice. Anything you do, it's good to practice. And then the last one is review your appearance. And I'm just going to show a couple funny slides. This is the way I just happened to look one day in my office at the VA as I was about to do telemedicine. I wasn't wearing the crown. It happened to be on the wall behind me. So I sat down, and you can see on the side there the different views I took when I was putting together a lecture another time, and I said, okay, what should you look like? What are the potential appearances a person could have? So it's important when you're doing telemedicine, know what you're getting into and what you're sharing. You can get away with wearing jeans, but make sure you have an appropriate appearance in what's going to be on camera. So we know what we're going to do. The question is, how are we going to do it? And if you want an overview of telerehab, there are different formats. And we'll go through each of these formats individually. The first being store and forward, where you have an image or a video, and it's just there, and then you send it to the other individual. Then you can do provider to patient at a facility, provider to provider. You can do direct to patient outside of a facility. And then we have these other applications that have been used more commercially, maybe not by the group of people that is in the general rehab community, but they're out there. And then home monitoring, which has been around for a while, but last year actually this year, I believe, was approved for Medicare coverage prior to the pandemic. So let's think about store and forward. What is store and forward? Well, our traditional view of store and forward, and it's been going on for quite some time. In fact, this was one of the first uses of telemedicine. I think it was actually about 40, 50 years ago for radiology. But, we all know radiologists can stay at home and see images from a hospital, their hospital, or actually they can see images from around the world and comment and do their reports that way. And that's your traditional store and forward. More recently, dermatologists have taken this on, and also retina physicians with a lot of the video for what retinal pictures look like. But there's another aspect of store and forward that we don't think about so much. And I'm showing here a slide of people in Africa, and the reason being that there's another way you can use store and forward, and that is for people in less developed economies. Because if you don't have such a HIPAA compliant platform, guess what? People may not have floors, but they can have cell phones. And so the store and forward use can be used in other places. And I'll talk a little bit about a study that, case series that was recently published in a bit. Okay, our next format, our next slide here is about using store and forward. And if you think about it, look at the date of this study. This goes to show how we just haven't jumped onto this technology, and it could have been done 10 years ago. So Halstead looked at 17 spinal cord patients with 20 wounds, and they looked at store and forward versus live images, not live images, on-site treatment. And they had 89% agreement for store and forward versus live decisions. The percent highest agreement was for the need to change wound care and the need for referral to another physician. And the lowest agreement was with the satisfaction for the treatment decisions and the need for additional information. All in all, though, it was pretty good. The thing is, this was like one study. And sadly, the number of studies that have been published in spinal cord injury with telehealth are very small. We'll talk about that in a minute. But just to realize that telemedicine has been more of a clinical development than anything. So the next thing is provider to patient at a facility. And this is really good if you've got satellite facilities in the community. And if you don't have therapists at those facilities, this is really good. But it's important that when you're doing it, you can work with a therapist or nurse or a trained presenter at least to provide the care. And so here what you see is, so you've got a doc doing a visit with a man, checking out his x-ray with him, with the nurse there. And then in another screen, you've got a therapist here. This worked really well for me when I was in the VA. And what we did was we set up a system where the physical therapists and occupational therapists would not physically go to our facilities in the community, but if a patient needed equipment, they could have their equipment training done via video. So we actually had like 10 different sites that one therapist could cover. They'd kind of be open on telemedicine for the day, and then if there was a patient up in one part of the state, they could see that patient, and then they could quickly go see a patient in another part of the state. So a person could just be seeing their doctor and need to get a walker and then immediately get some training from the therapist. So this can be beneficial. And this is also something I've done with weaning patients off of narcotics. As we're all aware of the opiate crisis, one of the many hats I've worn was being director of opiate safety, and switching patients from opiates to Suboxone is something I've done via telehealth from one facility to another facility, and then actually wean patients down off the medication, and they can go to the facility, be seen there, give their urine samples, etc. So there's a number of ways that this can be done, and I don't know why the slide just jumped, but all right. And then there's provider to provider, and certainly you could provide a consult this way to someone. You could be in one place, they could have no rehab professional, and you could provide help in terms of how to do an examination. If you think about it being an Asia examination, you could supervise this way. You could provide information about how to do a muscle test this way. So there's a lot of uses here that you could do. And I think this is very germane to rehabilitation, and that's the issue of team meetings. In inpatient rehab, we have team meetings. We have them in outpatient sometimes, but we probably don't use them as much as we could. And this one study looked at interfacility video conferences and basically found that the conferences were highly productive when they were done via telehealth. This is your Zoom meeting now, which is becoming commonplace. There was little time wasted on conflicts or discussion of unrelated topics, and most of the conversations were about significant changes of the client. So I think this is something to think about in terms of, especially for therapy. It would be great if a patient was coming to a rehab hospital and they were able to have a video transmission of the therapy at the acute care hospital to the rehab hospital. And similarly, from a rehab hospital going home, what if the community providers actually got to meet the patient with the inpatient rehab providers and do your transition this way? Or what if we were routinely bringing more family members into meetings? So a lot of good things we can do. And then finally, there's the direct to patient, which I think is really what took off this year. And partly, I think that's because of Medicare approving to pay for direct to patient care. I'm actually somewhat sad that Medicare decided to pay for telephone visits, because I think that it kind of went backwards a little bit. I don't know if any of you have participated in any of these visits, but to have a nurse call to review your medication so that the doctor could later get on the phone and talk to you kind of seems like too much of a second layer to me. So the direct to patient, I think, is much better done via video. Not that you couldn't do telephone calls for people that can't do it, but I kind of think the practitioner should be offering whichever option the patient would like. So what kind of direct to patient care is there if we think about rehab? Well, one use I think that we haven't taken advantage of enough is prehabilitation. Prior to surgery, working on what you need to do in advance of your hip surgery, or transferring the patient to rehab with pre-existing knowledge of what their status has been in acute care. And then transitioning to home from rehab with a focus on complications and functional status. So what if when you send your patient home from rehab, instead of doing what we've traditionally done and had the patient come back in for their first outpatient visit in like a month or so? Well, what if instead of doing that, you had a meeting with them the next day? And that patient could say, yeah, the first night, this is what happened. How do I do this? How do I do that? I think that would be a great benefit, both to staff and patients, because they would learn how things transition to home, and the patient would have the benefit and the security of knowing that their providers are still there for them. And educating patients and caregivers at home. Certainly education goes on after discharge. And then there's the other aspects, and that's telephone and video counseling for psych concerns and education. Certainly, education continues on a lifelong basis for all of us, and it should continue when you go home from rehabilitation. What else? Well, exercise programs. I think that Ashraf Gorgi is going to be speaking on Thursday about exercise programs in telehealth. You can also do integrative health techniques such as yoga and mindfulness. While we know now there are apps and online places this can get done, it's also worthwhile to be able to do this with your local provider. Then evaluating and treating pressure sores, and I'll give some examples of this. Certainly driving 2 hours, getting a van, waiting for the doctor, potentially going to a doctor and then waiting to get transferred in the doctor's office is not a good thing for pressure sores. So if a person can have their pressure sores either quickly evaluated using Store and Forward, or during doing a live call with the patient, can be a great thing. And this is also potentially a great way for a nurse at one facility to ensure that the home health nurses are doing the treatments the right way. Other things we can do are like new consults, physiatrists or therapists in acute care. follow-ups of previously seen patients, and this is really where I think this is the best. Doing new consults can be somewhat difficult because you can need to have an assistant with you, so it can take a little bit longer. But with follow-ups, generally we know the patients, we know the people we've seen, we've had that hands-on, and so follow-ups can work well. And then wheelchair and other equipment needs. This has been a well-documented, I think, way to do telemedicine. What about specialty services? Urology follow-ups. If a person has a urinary tract infection, this is a great reason to get a quick visit where you're just seeing the individual. They can eyeball you, see what you're looking like, get vital signs. But you can also do follow-ups in terms of bladder volumes, checking on people's catheterizations. I'm a big proponent of having some type of face-to-face conversation. I think that's really important. And doing this as opposed to just trading numbers, I think is a worthwhile action. Then GI evaluations. How's the person's bowel program going? Is it better? Do they need to change things? You don't always have to come in to be seen for this kind of action to be done. Nutrition management, checking somebody's weight. How are they doing on their diet? Incredible way to do this. Go into the person's kitchen. Actually have them show you what's in their refrigerator. And what I do now is I do sexuality education and management. I see people, I actively see people in Boston. I'm in Alabama, but I see people at Spalding for sexuality consults. And so people, by having access to a person's chart and knowing their meds, their neurologic status, and being able to see them, I can pretty easily give them an overview and treat their sexual dysfunction just using telehealth. We talked a little bit about management of pain, adjusting medicines, weaning medications. This can also certainly be done with spasticity. And I mean, there are really endless possibilities here. So what are some other reasons for telerehabilitation? Long distance travel to specialty centers, providing co-treatment for specialties, discussing the need for nursing home or assisted living placement, marital and family counseling. I have done, I've seen couples for their evaluations, which I definitely think it's a lot easier for two people to be seen at home together than to have to go to a facility. And this is all pre-COVID, the telehealth I've done. Replacing visits to your facility for people's evaluations. And this, interestingly, what I was thinking about with this, and I don't know if people have been doing this or not yet, but is, so say a patient wants to go to a rehab hospital and they haven't seen the rehab hospital yet. Well, what about giving them a tour live? Not just having them watch a video that you've had that's been made for everyone, but actually giving this individual a tour to what's going on right now at the facility. Recreational therapy, personal coaching, respiratory evaluations, and then facilitating research and education. And I really think in terms of the issue of research, so much more can be done by using iPads, iPhones, other devices than actually bringing people in for follow-up of visits. The other thing is that, when we get, this is out of the SCI group, when we get to the point where there are cures for SCI, I really do think we're going to need to have a acute care telehealth setup such as is available for stroke so patients can be triaged. Web-based therapy is out there. Certainly everyone gets ads for web-based exercise, and similarly, this can be done with therapy. There's been some studies done on this, but we definitely need more research. And then there's mHealth, and I'm just, this is way too much of a topic to go over. Just want to say that, all of these areas of focus really create a system. And when I think of it as a telerehab system of care where we go from, just like you might have a model spinal cord injury system, you really need your telerehabilitation system to go from one end of the spectrum to the other. And then, I mean, for instance, if we take the issue of diabetes and the Dexcom, if a person's willing to use it, it's a great advantage. And then finally, home monitoring. And I don't think we've used home monitoring enough in rehab. This is an opportunity for people to, get out to their patient population and not just take care of them, but take care of them at a higher level. And it's not saying that we would replace primary care docs, but our populations that we take care of that go to inpatient rehabilitation certainly would qualify many times for home monitoring. So I want to give a couple examples now. And this first is an example of really using telemedicine or telerehab, as I like to call it, for spinal cord injured patients with pressure sores. And I do a lot of work internationally. And this is a colleague of mine in Norway has focused in doing her PhD on telemedicine for pressure sores. And really, Norway has taken on telehealth. One difference between the US and other countries is clearly that we don't have national health care. And so things are a little bit different. But if you look at her data, here, just an example of one patient, a hospitalization would cost the equivalent of $150,000, whereas using telehealth, and this is the same outcomes in comparable patients, the video consultation cost was 3.2% of the hospitalization cost. And she actually did this with a whole team that saw people, not just one person, but actually a whole team-based approach. And then similarly, if you look at the telehealth costs for outpatient, they were, instead of 5% for the inpatient, they were 15% of outpatient costs. So there is some data there on the cost benefits. If you think about how much we might pay for an ambulance to take a patient to a hospital, there can definitely be a great cost benefit in the US too. So my own work, I actually did a VA-funded project, more a development project than anything else, so I didn't really publish this as a research study. But what I did was I started a video to home project at the Birmingham VA where I saw people at home versus at the regular facility, and also had the therapist, worked with the therapist who did video to home, but also video to other sites. And our goal was really to just demonstrate efficacy, determine diagnoses, outcomes, and then document the environmental benefits. And it was interesting because in 2 years, we counted how many miles we had saved, and we had saved almost 500,000 miles, which is like driving around the world 19 times. So these numbers add up quickly. And when you look at patient satisfaction for telehealth, whenever I've looked at numbers, it's always been 95%, 90%. The toughest thing with telehealth is that you might miss visits. So you have to be careful about that. But when people get it, they really get it, and they get used to it, and they're quite happy. So just a couple examples of people that I've seen in cases in the past. One case is a 25-year-old male with a C7 complete tetraplegia. I got him in Alabama. He had been sent home from an inpatient rehab program, and this was actually pre-opiate crisis. He was sent home on methadone and Valium, age 25. He had some shoulder problems, which is how he ended up on methadone. And that ruffled my feathers tremendously, and I was not happy with this treatment plan they had. So he lived 90 miles away. So I weaned him off the meds, but I didn't have him keep coming back to me. But I also didn't say, okay, wean yourself down. I saw him regularly. I saw him weekly. I titrated him down on the methadone, titrated him down on the Valium, and at the same time brought him up on baclofen and other meds for neuropathic pain. And we did this over a few months, and during the process saved 180 miles driving every session. So I think that's, an example of a success story that you could use for telehealth. Another patient is a man with incomplete paraplegia and a failed total knee. So because he had the failed total knee, he needed to go get replacement, and he was in inpatient care for a while. But then when he went home, he was far from ready to stop having therapy. And so what we did was we engaged him in telerehab for therapy to supplement outside therapy. And he worked on transfers, lower extremity range, strengthening, and gait. And in this case, he saved 160 miles per session and was able to be successfully rehabilitated. So these are just some examples of how you can combine using telemedicine with your regular care. And I hope that people do this once the pandemic is settled down. So what about spinal cord injury and telemedicine around the world? Well, we did a narrative review, which is published in Spinal Cord, and it's available to anyone that wants to look it up. And at that time, there were really only 29 studies, and 13 of those studies provided care using telephone only. 7 was video plus voice, 5 were only giving data, and 1 was a robotic voice. 2 were provider to provider, 13 direct to consumer, 1 store and forward, 2 web-based, and 2 interactive home monitoring. So there's been some work done, but not enough published, at least in spinal cord injury. But this is changing, and I will give a little, I do edit the journal Spinal Cord Series and Cases, and we do try to focus on some of these papers, and I know there's one that I hope to accept soon on telespinal cord injury. But there's one that was published last fall, which I'd like to talk about, because I think it was really worthwhile. And what this is 2 case studies in India. And so if we think about now in the issue of HIPAA compliance, this is a little different than I think something we would do here, but I think it's very unique and very good. So Nishu Tyagi over at the Indian Spinal Injury Center has been doing telehealth there for a few years. And actually what she does is she uses WhatsApp. And so they had a project where they sent people home. They did an assessment of their functional potential at the time of discharge prior to their team conference. They did a team conference, got the patient's functional potential, sent them home, and they saw them again after 1 month at home and documented how their function had changed. And in fact, yes, it changed dramatically, and not for the better, actually for the worse. So the way she learned about their function, though, was through video. She had videos of people when they got home, just transferred using WhatsApp. And then based upon those videos, they made new educational videos for the people with spinal cord injuries to do at home. And so they documented how functional status went down for a month, and then after getting the video education, functional status went back up to where it was and even better. So I think this is a really important thing to think about. There's so much else we can do, and we need to make what we do targeting the population. It's not always about the greatest technology in the world. Sometimes it's about just using technology in the right places. So I'm going to digress a little bit, but I'll do it quickly. Even before Corona, times were changing. And I got involved in telemedicine partly because I really think it's a green form of healthcare. And I've tried to talk about telemedicine and tried to talk about the impacts of disasters and climate change on disability ad nauseum. I've tried to present at many meetings and couldn't get people to say this was important enough to put on an agenda. So in June of 2019, I decided to take a break from practice to walk. And I decided I'm going to walk and give grand rounds as opposed to just trying to go to meetings and talk about these topics. So I looked at accessibility and walked on the roads. This is my husband in the middle screen there with the hat on. But I just want to highlight here how inaccessible our roads are, and how few people you see outside in chairs. Now, that's important. And I also thought that you know what, we need to prepare as a community and get together in community, oddly, for what happened this year, and be prepared for disasters. And the reason I put this together with telemedicine is why? Well, telemedicine, and this is interesting because you saw that original slide from Africa. It's important, I think, not just to be local when you work in healthcare. I think that anybody that goes into healthcare goes to healthcare because they think about people, and I'm very, I don't really believe in borders. I think people are people. So I think telemedicine to me comes up as a solution to going to the future. And what I wanted to do, and I did, was start a nonprofit. And the initial goal of the nonprofit was to talk about sustainability and quality of life for people with disabilities, but also to develop a framework for the use of volunteer telemedicine consults in disaster areas. And as I thought about this, I didn't just think about, well, I did. I just thought about disaster areas. I thought about climate change. I thought about hurricanes. I thought about floods. I thought about extreme heat, extreme colds, etc. I didn't really think about a pandemic, to be honest. That was not on my radar screen. So as we were starting to work on how to operationalize the telerehab consults in India this year, lo and behold, coronavirus came and changed everything. And so what we did was, when we're still thinking about the conversation of telerehabilitation, what we realized was that by seeing people one-on-one doing telemedicine, you can't reach as many people as if you did just trying to educate people. So actually, we ended up developing a YouTube channel with a group of people internationally, and are now posting educational videos and trying to give people the therapy they need via the video. And one of the people that's on the channel is Nishu Tyagi, who's the woman that would do all the store and forward work in India. And so we're trying to bridge that gap now by using telehealth versus telemedicine. And I think what's going to happen with time is that we're going to all have to do this. We're going to have to look at, how do we balance? I think as we go to the future, and I'm hoping that we don't know how long this coronavirus will last. I guess these days it seems like it's going to last a long time. But I'm hoping that if we look at the future positively, we're going to find out that we can use telehealth, and it will help us with increasing accessibility of the physical environment and virtual environment. And that as leaders in rehabilitation, we will think about the need for advocacy, because this is certainly important, and we'll use more telemedicine and more e-health. So as Corona has rapidly taken over the world, I think it's a good idea to think about the barriers that we've had and the benefits of telehealth. The barriers in the US we've had has been funding, insurance, licensure. That's still a problem. There's the state compacts, but that's got a ways to go. Provider acceptance, which hopefully some more providers have agreed to accept the concept now. Not all conditions are treatable. Certainly, you're not going to do surgery via telehealth. You're not going to do an injection via telehealth. And you do need equipment. But most people have smartphones these days. So for rehab, some of that equipment may not be that difficult to have. But there are benefits. There's a lower cost. There's the long-term societal savings. There's the ease to the patient, decreased travel time and convenience, increased patient satisfaction, and above all, now that we throw Corona into the mix, there's safety. So my goal is that, or not my goal, my vision, thoughts are that in the future, we may use telerehab across international borders for coaching. We can do this for training and education, and for super specialization and consultation. That we can use telespinal cord injury within our licensure limits to save time and money and the environment, and use telerehab to help in times of disasters. So in summary, at least in my opinion, telehealth is the future. The more we use telehealth, the more people will want to use telehealth, and we need to balance though. I think as we come out of Corona, we'll have a balance of private visits and general online content and telehealth visits and face-to-face. So that's all I had to say, and hope you check out Sustain Our Abilities and consider joining our mission, and let's all look to the future with hope and action. And that's my end of the show. So
Thank you so much, Dr. Alexander.
Sure.
That was a really wonderful set of experiences and data to share with all of us. Thank you so much for that. And at this time, I invite our audience members to share any questions they may have using the chat feature. And as others are formulating their questions, I'm going to ask a question on behalf of Dr. John Morris, which is, have you had patients who've had limited access to internet and inconsistent cell phone access? Have you found workarounds to still be able to deliver telehealth despite those technological challenges?
Yes, well, one of the issues is definitely there are issues with connectivity for people. One thing to do in those situations is, in the VA situation, what we did was send people to our community clinics. You know, they don't always have to do telehealth from home, and the best thing we've come up with is having people to go to their community clinics. There was actually an FCC grant available recently to help with providing funding for devices and potentially broadband for people in the US, but that came out about over a month ago, so I doubt any of that money is still available. But you know, that's why sometimes the option of doing it at home versus in the local site, like for instance, if you're in Boston and there's a site like outside of Boston that a person can go to as opposed to going into the city, that may still be an advantage.
Excellent. Thank you very much. And I also have a question from Dr. Margaret Nosek. Can you say more about licensure and liability insurance that varies from state to state and country to country with respect to telerehab practice?
Sure. Well, licensure varies based on state to state. So in the US, we've got to go look, and this is a difficult thing. In the US, you've actually got to go look and see what the state the person is in requires for licensure. So for instance, I live in Alabama. I am licensed in Alabama, Florida, and Massachusetts. So I can see patients in Massachusetts via telehealth. No problem. I can see people in Florida via telehealth. Can I see people in Texas? No. You need to be licensed in the state where the individual lives. And there are some states where that's pretty easy to do, that you don't have to get a full license. You can just get a telehealth permit, but it is a process. And there also is the state compact where there's like 19 states that make it fairly easy to get a license from state to state, but you still have to do that. But the only way to find out about that is actually go online and check exactly what the licensure requirements is. The issue of liability insurance or malpractice insurance, when you get your malpractice insurance, you've just got to say you do telehealth. I actually, after about 10 years of looking into this and deciding this, just got my own malpractice insurance to do telehealth, and was able to do so. Now, it wasn't so easy to get telehealth malpractice in the back, but the world is changing, and so insurance carriers are starting to pay attention to it. In terms of country to country, I haven't bridged that gap. There are a number of countries that have done that, but every country, you've got to be licensed in those countries too. Now, this is aside from if you're doing emergency activities. You can get there and do some emergency activities for a short period of time. And there is a workaround that if you're seeing people from one state to another, as long as you have a referring doctor and your report's just going back to the referring doctor, you can sometimes do that.
Very good. I have a question, Dr. Alexander, that sort of relates to something John Morris had asked earlier. I know you mentioned that many individuals who participate in telerehabilitation are very satisfied with it, but have you noticed any patterns in the kinds of individuals who may be either resistant to it or concerned about it or uncomfortable with it, and what strategies have been used to help them along and be participants?
Honestly, I can't say that there's been a pattern that I've seen about people that don't want to do it. Certainly, if somebody just says no, then you're not going to be able to let them participate. But I've had success with elderly people. In fact, some of the best people that I've worked with have been elderly. I think the toughest thing is, in terms of actually going into a practice, I think the toughest thing is making sure that people don't miss their appointments. I think that's very important. And I've seen that some of the at least here, I've had a couple telehealth visits myself, and what's interesting is they actually had so much assistance for the telehealth visits. I just realized there's no way that that could ultimately be financially viable. You know, they had a nurse calling the patient in advance, asking all the questions before the doctor would come onto the appointment. And as I've done telehealth, it's always been like, okay, the patient learns, they're trained to do the appointment, but then the patient goes direct to the provider. So sometimes you might have to call people a couple times. You might have to have a couple appointments before they get used to it. But once they get used to it, things generally do work. I haven't found a specific subgroup of people that have a hard time.
Very good. And I'll again encourage audience members, if you haven't asked a question already in the chat, to feel free and add one. And as you're thinking of other possible questions, I wanted to ask a question about Telerehab International. And one of the stated goals of that organization, as you said, is to develop a framework for the use of volunteer telemedicine consults in disaster areas. And as you alluded to in your presentation, you know, we're in the middle of what one could consider a disaster with the COVID pandemic that differs very much, I think, from what most of us had in our heads when we were thinking about disasters. So I'm curious about what you've observed so far and maybe what you're thinking about and how a disaster or challenge of this nature compares with natural disasters and other things that we might have had in mind more prominently before, and how we might need to adapt our practice in this situation to address this kind of challenge.
Well, if you look at any of the information out there, you will hear that disasters will increase in frequency. And that's pretty much been agreed upon. So if we think about disasters we should anticipate in the future, I would be thinking about the weather-related disasters or natural disasters, such as disasters related to hurricanes or heat or drought. So these disasters are more localized. And when you think about these disasters, you could potentially send people to the place to help out. And traditionally, that's been what's happened. If there's been an earthquake, people would go there. You'd have your missions. My initial goal with Telerehabilitation International was to be able to replace the need for missions so that you could provide services relatively quickly. And as a rehabilitation practitioner, I think that a lot of us can do these things via video. And I think that saves time and, you know, saves the region from having another body on site. Having said that, people always say, well, what about the issue of actually being able to communicate? So my initial vision was that we would do provider to provider consults in disaster areas so that we would be speaking to the physician saying, okay, how can you triage this patient? How can you triage that patient? So that was my initial vision with this. Turns out, though, when you think about a pandemic, yes, things are different. The disaster is everywhere, so you can't be everywhere. And all of a sudden, people realized, well, we could talk to our docs and just make the patient stay home. And I think even if it wasn't professed on the media, I think people would have started doing telehealth visits on their own. So they're very different situations, and I think your need is different at the different times. The ironic thing to me is that I'm a member of ISPRM, and I joined the disaster group for ISPRM. And when I brought up the issue of climate change and disasters, the leader of the disaster group said, oh, I never thought about that. I never think of climate change and disasters. So sadly, what's happening is, and I don't know if it's because it's politicized or what, but this person wasn't from the US. We're not thinking so much of where we need to go in rehab in terms of future disasters. We're very focused on the now and the here and not on the preparedness aspect of things. So I think that as we get into these areas, I think that not only the providers, but the accrediting bodies need to start thinking about educating people and saying, okay, if there is a disaster, what are you going to do? And telehealth is part of that solution. And that's why I also think that, yeah, maybe I should have been paying more attention to social media throughout the years and trying to get information out direct to patients. You know, being a researcher and educator, I realized the reason I wrote my book was that I realized, oh, I give lectures all the time, but why am I not just putting the information out there so people can read it directly? So I think that we have to look at all these different aspects of things and try to tailor what we are doing to the actual needs of the person and the situation and try to balance it. Does that answer your question?
It does. Thank you very much. And that also leads me to remind everyone to take a look on YouTube at Sustain Our Abilities and what's been placed there to help us learn more and be more sensitized to these issues.
Please subscribe, and also if you want to join us, we'd love to have you on board.
Wonderful. Well, I see no new questions from the audience, and I'm so grateful for all that you've shared with us today. Are there any parting comments you'd like to make, Dr. Alexander, before I do some final housekeeping?
Well, I think as you can all tell, I'm very passionate about the benefits and potential for telerehabilitation, and happy to work with people or talk about it further. If anybody has an interest, you can get me at malexander@telerehabinternational.org, and look forward to watching this field grow.
Wonderful. And I just want to let everyone know that I'm so grateful to everyone who's participated today. And a recording of this talk will be available in the next 24 to 48 hours and will be accessible via the ACRM website, which will link to the various channels on which that video will appear. And so I encourage those of you who attended to let your colleagues know about today's presentation and encourage them to view the recording in the coming days. And with that, this concludes our episode for today. I wish everyone good health and good humor in these extraordinary times, and hope to have you join us again at the next webinar. Thank you all so much.
Thank you.